topic that I am going to discuss is ODC. Can anybody tell me what is ODC? Can you post in this your chat box what is ODC? Lactate physiology, tracheal anatomy, and in that I would be also discussing about tracheostomy. Before that, a very honest question to all of you, because I always start with a little bit of bang. How is the Joes at this point of time, 1 month before your exam? Your 3 years of hard work is right now getting tested, and this is the last month of the your 3 months of extensive training. Your the perseverance, resilience, your all hard work, struggle that is getting tested, and we are here to witness that magnificent journey of your last 3 years, and we will be definitely helping you to cross this hurdle with flying colors. So the first topic that I am going to discuss is decoding oxyhemoglobin dissociation curve. And as you know, this is one of the favorite question from the physiology point of view, critical care physiology point of view. And this is not only significant, if I will be very honest, related to exam, but also as intensivist when we are dealing with oxygen, carbon dioxide, mechanical ventilation, hemoglobin, ABG. So it is something expected naturally from intensivists like us to know in detail about oxyhemoglobin dissociation curve. Now, so what is oxygen hemoglobin dissociation curve? If that will be asked in your exam next month on 17th of January, what you are going to write? It's a graph showing the relationship between PaO2 and hemoglobin saturation, which is SaO2. So it is a relationship curve or graph between PaO2 and SaO2. As simple as that. It's sigmoidal shape. The graph is of sigmoidal shape. I will be discussing in detail why it is sigmoidal. That reflects oxygen loading and unloading dynamics. So you just try to understand the words, because in your exam you cannot write maybe 3 pages, 4 pages about this type of, I would say, a very practical, very basic question. So there are sentences that you can remember, and I will be helping you with the art of writing in short, a very extensive discussion that would be summarized in one maybe paragraph. Now, this graph is of sigmoidal shape that reflects oxygen loading and unloading dynamics. In this graph, there are two axes, x-axis and y-axis. I will be showing you the picture also, the graph also. The x-axis is having PaO2 in millimeter mercury, and y-axis is having saturation, with its hemoglobin saturation, SaO2 in percentage. Now, why we want to learn about oxygen hemoglobin dissociation curve? Because this is essential for understanding oxygen transport and tissue oxygenation. So there are three things which is right now of concern to me. One is this graph, this sigmoidal shape reflects oxygen loading and unloading, and this curve or graph is also like essential for understanding oxygen transport and tissue oxygenation. Now, this is the oxygen hemoglobin dissociation curve. Very easy to draw in your exam. So try to remember there are two axes, x-axis, y-axis. In x-axis, as I have told, PaO2 is in the x-axis, and this is all in the millimeter mercury. While in the y-axis, it is hemoglobin saturation in the percentage, 0 to 100, and here 0 to 100. And what this is the graph or curve, oxyhemoglobin dissociation curve. And you can see here, this is sigmoidal shape. Now, this red color coming from here and intersecting here. Can anybody tell me what does it signify? Anyone who wants to post in the chat box? Because this is all like about the oxygen hemoglobin dissociation curve. Anyone? Yeah. Darshan must be knowing, because I am unable to share, check the chat box. But if you are still not very sure what is this, definitely this needs introspection, because critical care is all about oxygen hemoglobin dissociation curve. This is all about PaO2, SaO2, or like carbon dioxide, methemoglobin, whatever like no forms of hemoglobin, the ABG. So all related to this PaO2, SaO2 is critical care. Now, this is P50. What is P50? You can see here, it is already mentioned here P50, that P50 is the partial pressure of oxygen at which hemoglobin is 50% saturated. Clear? Now we are taking this is from 0 to 100% saturation related to hemoglobin. So this is SaO2. So we are taking the 50% value and we have to correspond it with the PaO2. So it falls or it joins in the sigmoidal curve at the 25 millimeter mercury around. So it would be 25 or 27 millimeter mercury. So PO2 is around 25 millimeter mercury. At this point, your hemoglobin oxygen saturation is 50%, or the you can say the saturation is 50%. Now, there is a the correlation PaO2 and SaO2, and you can see here 25 or 27 is 50% oxygen saturation, and after that you see 30 would be 60, 40 would be 75. So each 10 is right now going up, 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 and almost PaO2 of 100 millimeter mercury is 100% oxygen saturation. SaO2 of 100% or 98%. So this is the relationship between PaO2 and SaO2. But the P50 is the partial pressure of oxygen at which hemoglobin is 50% saturated. Now, the sigmoidal shape. Why it is sigmoidal shape? Why it is not linear? Because it reflects hemoglobin's affinity that will change for the oxygen. Now, the key feature of this curve, because the question is oxygen hemoglobin dissociation curve. So you have to describe the curve in detail. So the curve has two portions. I will be again and again in 2 to 3 slides try to explain to you. It has two portions. One is T portion. If you see, there is a steep portion and there is a flat portion. This is the flat portion and this is the steep portion. Now, if you will be trying to understand what is the meaning of the steep portion and flat portion, the steep portion is from the PaO2 0 almost to 40 millimeter mercury. And you can see here, there is rapid increase in the hemoglobin saturation as oxygen binds. And the principle behind this affinity of oxygen towards hemoglobin is, what is the terminology used? Can anybody mention in the chat box? Okay, I will be explaining that. Now, this also will indicate efficient oxygen loading in tissues during metabolic demand in this tip portion. Now, in the flat portion where the PaO2 has already crossed 50, so from 50 to 100 millimeter mercury, the flat portion or the plateau portion represents near maximal hemoglobin saturation. Now, this supports oxygen loading in the lungs even when there is fluctuation in the oxygen level. That means the hemoglobin will try to combine or bind with the oxygen that is getting in the lungs. So this happens more in the lungs, and the steep portion would be more of oxygen loading in the tissues to help for the perfusion, for the metabolic demand of the end organs. Now, low affinity oxygen unloading, and this time there would be low affinity oxygen unloading happening in the tissues, but in the lungs there would be oxygen loading that would be continuing. Now, the mechanism that I was mentioning is positive cooperative. You all have to write at least in this like a curve. If that would be a question about the curve, you have to draw that. You have to mention the relationship between PaO2 and SaO2. Now you have to also mention that this is a sigmoidal curve or sigmoidal shape. This would be having two portions. One is steep portion, one is flat portion. And the mechanism behind this curve is positive cooperative. What do you mean by positive cooperative? That there would be binding of oxygen molecule with the hemoglobin. Now, binding of one oxygen molecule enhances affinity for the next. That means first oxygen binding to the hemoglobin, affinity will increase little bit. Now the second oxygen will bind now. There would be also like now more affinity to bind with the third oxygen molecule. Now this will happen till it will bind with four molecules of oxygen. One hemoglobin will normally bind with four molecules of oxygen. So this is called as positive cooperative. That means one will be following or cooperating for the binding of the second one. Now, highest affinity occurs at PaO2 of 60 to 100 millimeter mercury. That will be allowing nearly SaO2 oxygen saturation of 100%. Now, what is the clinical relevance? That would be maintaining oxygen delivery to the tissues under varying conditions, and that also will explain the efficient oxygen unloading in the tissues and loading in the lungs. This is quite like clear. Oxygen will be first loaded in the lungs, and that would be like transferred through the hemoglobin binding to the distant organs, and in the tissues it would be unloaded. So this is all about sigmoidal shape, but I will be again explaining in little bit detail about the flat portion and the steep portion. Now, the flat portion represents high oxygen saturation because already the PaO2 has crossed 50 or 60 millimeter mercury. Now, this occurs at higher PaO2 typically found in the lungs, 60 to 100 millimeter mercury. Now, at this point of time, when it is almost reaching to 90 to 100 millimeter mercury, your hemoglobin saturation is almost touching 90%. That means ensuring maximal lung oxygen loading. So the loading is now good. Now, what is the significance of this, the loading in the lungs? Now, this would be like acting as a buffer against oxygen drop. That means there is enough oxygen right now in our body, in the lungs, that has been already bound to the hemoglobin, that if the PaO2 decreases slightly, in case opioid anesthesia, if in case you are actually exposed to a high altitude, or there is mild hypoventilation happening, that means your body is right now not getting that amount of oxygen that was like previously getting. So there won't be any problem with oxygen delivery to tissues, because already there is enough oxygen that has been loaded in the lungs, because you are already in the flatter portion of the curve. Clear? Now, this would be also, you can take it as a reserve capacity. What do you mean by reserve capacity? That means your hemoglobin is right now maintaining a reservoir of oxygen under normal physiologic conditions. Clear? So this is the significance about the flat portion. Now come to the steep portion where your PaO2 is around 50 or less than that. Now that would be representing rapid oxygen release, and that occurs at lower PaO2 level, maybe around 50 or 60 PaO2, typically seen in systemic capillaries, where oxygen is unloaded to the tissues, where your like the capillary oxygen level is around 20 to 40 millimeter mercury. You can take it as a venous blood. Arterial blood would be, which would be the saturation would be more than 90%. But if you are going for your mixed venous oxygen saturation, or your like the systemic venous oxygen saturation, SCBO2 or SBO2, that would be the steep portion where your PaO2 is already low. Now, what is the significance of that? A small decrease in PaO2 cause a significant drop in the oxygen saturation that would be facilitating oxygen release to the tissues, because now the tissues demand oxygen more. So you cannot keep or bind the oxygen to a great extent. The body, the tissue, then require the oxygen, that would be helpful for their metabolic demand. That way, this would be the steep portion would be helping to release the oxygen with less affinity. Now the significance, as we have already discussed, efficient oxygen delivery to tissues with high metabolic demand, point number one, and that also would be more sensitive to the local changes. That local changes would be, maybe there would be pH will be high in case of metabolic acidosis, maybe in case of hyperthermia, in case of the less of 2,3 dpg. So that would be making your oxygen delivery to the tissues in a better way. like you are during the exercise or hypoxia. That would be also, I will be discussing that part in the next slide. Now, in summary, if I will be dissecting, analyzing the oxygen hemoglobin dissociation curve, so the flat person ensures that there is a stable oxygen loading in the lungs, providing a safety margin to our whole body. Now, the steep person ensures efficient oxygen unloading in the tissues, especially during increased metabolic activity. Now, I hope that I have tried to explain you in detail. Now, there is a situation I have already discussed. This is the arterial blood where your oxygen hemoglobin saturation is 100 and your PaO2 is almost touching 100. And there is another blood which is mixed venous pressure or SbO2 where your PaO2 would be around 40 to 50 and your oxygen saturation, what we normally observe, is around 75%. And that's why our target during EGDT trial was also to reach around at least 70%. 65 to 70% because of this principle only, oxygen hemoglobin dissociation curve. Now, the sigmoidal shape of the oxyhemoglobin dissociation curve helps to explain why oxygen is loaded into the pulmonary capillary blood from alveolar gas and unloaded from the systemic capillaries into the tissues. Clear? Now, at the highest value of the arterial blood oxygen, that is the systemic arterial blood, the affinity of the hemoglobin for oxygen is highest, which is the yellow color here. And at lower value of PaO2, that is mixed venous oxygen blood, affinity for oxygen is lower. That why the oxygen unloading to the tissue would be better. So the end organs will be getting more oxygen. Now, in other words, if I will be again explaining the same thing, what happens in the lungs and in the tissues, already I have explained, but you can write in this way also. What happens in the lungs? PaO2 is 100 millimeter mercury. Saturation is around 100%. Affinity is highest due to positive cooperative. Oxygen is tightly bound to the hemoglobin. The significance is maximal oxygen loading to the arterial blood from the alveolar gas. And that would be having the flat portion of your oxygen hemoglobin dissociation curve with PaO2 60 to 100 millimeter mercury. Clear? Now in the tissues, what happens? PaO2 would be around 40 to 50. Saturation, I have already explained, around 75%. Affinity would be lower. Oxygen would be readily unloaded to the tissues, to the end organs. The significance would be to facilitate oxygen delivery to meet tissue metabolic demand. And that would be for better consuming the oxygen in the tissues. Now, there would be the third part that you have to write in your exam. What causes your oxygen hemoglobin dissociation curve to shift to right? What causes oxygen hemoglobin dissociation curve to shift to left? Because that is something which we need to understand also to utilize our clinical acumen in correcting the problem in the ICU. Now, to the right, try to remember these four things. PCO2 if it will be high, pH if it would be low, that means acidosis, then hypercarbia or hypercapnia, increased temperature, that means hyperthermia, and increased 2,3 DPG. These are the four things that we have already read during our Ganam days in our physiology, MBBS days. Now, what causes ODC to shift to the left? If it will be alkalosis, or alkalosis may be respiratory, may be metabolic. Now, hypothermia and decrease in the 2,3 DPG. Also, the another factor which you also remember is the fetal hemoglobin. So this would be causing your oxygen hemoglobin dissociation curve to the left. And you can draw in your exam also. This would be right now making your oxygen hemoglobin dissociation curve to the right, little bit to the right here. Now, here it would be left. That means your P25, P50 here would be your PaO2 would be less or the same level of your P50. That means the shifts to the right are associated with increase in the P50 here. Before, like in the normal oxygen hemoglobin dissociation curve, it will be remaining around 25 to 27 millimeter mercury. But if you are actually shifting your ODC to the right, you are actually increasing your P50. Maybe it would be around 40 and decrease affinity because it would be releasing the oxygen at the tissue level. Now, shift to the left are associated with decreased P50. Now, it would be almost, you can say, 12.5 or 15, the P50, and there would be increased affinity for the your oxygen. So this is something you have to also write or draw in your answer sheet. Now, what is the significance of the right shift? I have already explained. That would be facilitating oxygen delivery during physiological like implications would be in the exercise, during your exercise, in your gym, fever, metabolic stress like sepsis, shock. Now, left shift, the challenges would be there will not be oxygen delivery as easy like before. So that would be impairing oxygen delivery to the tissues because your affinity is right now more. And that can be seen in clinical scenarios for us: carbon monoxide poisoning, hypothermia, and alkalosis. So you remember what are the factors that shift ODC to the right, what are the factors that would be shifting your ODC to the left. Now, I will be giving one clinical example of oxygen hemoglobin dissociation curve in presence of carbon monoxide poisoning. Now, what will happen if you will be having a patient with carbon monoxide poisoning? There would be decreased oxygen binding with the hemoglobin. Why? Because carbon monoxide will take its place. That would be binding hemoglobin with 250 times higher affinity than oxygen, forming carboxyhemoglobin. Now, what will happen if your carboxyhemoglobin will be the predominant hemoglobin bound to the the carbon monoxide? That would be reducing the available oxygen binding sites on the hemoglobin because already all the the receptors, the sites are actually filled with carbon monoxide. Now, if carbon monoxide occupies 50% of the binding sites, oxygen content and delivery to tissues decrease by 50%. So that is a real concern for the clinicians. Now, that would be causing left shift of the curve because the remaining heme groups have increased affinity for oxygen. P50 decreases, making oxygen unloading into tissues more difficult. And as a result, what will happen? There would be reduced oxygen delivery due to decreased oxygen carrying capacity, and there would be impaired tissue oxygenation as the tightly bound oxygen is now not very easy to release or harder to release. So this is the significance of the oxygen hemoglobin dissociation curve. And you can see here, in presence of carbon monoxide, your oxygen hemoglobin dissociation curve is looking like this. It is not looking like the previous sigmoidal shape. Rather, it would be only showing your saturation level. You can see your the hemoglobin saturation is almost 50% because the rest are occupied with carbon monoxide, and you can see your PaO2 would be more, but your hemoglobin saturation would be only around 50%. Clear? So carbon monoxide reduces the number of sites available for oxygen binding to hemoglobin, and that would be causing your oxygen hemoglobin dissociation curve to the left. Now, I am not going into this is a clinical case, but yes, you can get this type of question scenario in your examination, maybe in your theory, maybe in your practical, that a 55-year-old man warmed his like car in a garage and inhaled exhaust fumes. He was confused and breathing rapidly. Now, the arterial blood gas value, what you have done in your emergency department, the PaO2 is 660, PaCO2 is 36. pH is 7.43, but the saturation is showing 60%. I think all of you are getting what I am trying to convey here. Here, the carbon monoxide poisoning has caused all these things. You will be getting PaO2 to be very high, 660, but your saturation would be only remaining at the level of 60%. The reason I have already explained, because of the left shift of the oxyhemoglobin dissociation curve. P50 is decreased and there would be left shift of the oxyhemoglobin dissociation curve. Now, the treatment would be administer 100% oxygen to displace carbon monoxide from the hemoglobin rapidly, so that the hemoglobin will be now the added to the or combined with the your oxygen. Now, in summary, if you will be getting a question on the oxygen hemoglobin dissociation curve, you have to mention all the things what I have already mentioned, but you have to definitely remember to mention about the sigmoidal curve. The shape of the ODC is sigmoidal curve. The right and left shift about P50 value and how it would be helping to integrate this curve knowledge into critical care decision making. Now, I am now sharing with you three clinical scenario questions. I'm not mentioning or I am not expecting answer from you, but a question can come in this way rather than writing or mentioning oxygen hemoglobin dissociation curve for 10 marks. They would be expecting a question in a clinical format. A patient in hypothermia, core temperature of 30 degrees centigrade, is admitted to the ICU. Now, how does hypothermia alter the oxygen hemoglobin dissociation curve, and what strategies would you employ to optimize oxygen delivery? This can be the question format number one. Now, the second one, you are managing a critically ill patient with metabolic alkalosis, pH of 7.6. How does alkalosis affect the oxygen hemoglobin dissociation curve? And what are the risks of impaired tissue oxygenation? The same thing. Now, the third one is quite interesting. During a code blue, a patient has a PaO2 of 150 millimeter, but SpO2 is very low. The peripheral oxygen saturation is hardly 35 to 40%. Now, what could explain this discrepancy, and how would be the oxygen hemoglobin dissociation curve help you interpret this situation? Now, if you understand the concept of oxygen hemoglobin dissociation curve, you can easily get, I bet, 9 out of 10 if this will be a question in your upcoming exam. Now, I am not mentioning these are the answers in short one-liners that I have already explained. This would be hypothermia question number one, reducing oxygen unloading to the tissues. The strategies would be to rewarming, ensure adequate tissue perfusion, monitor oxygen delivery closely. The second one would be again the same, effect on the curve, shifting the curve to the left, impairing oxygen release at the tissue level. And what will be the risk? Despite your normal oxygen saturation, you will be continuously getting tissue hypoxia. So you have to correct the underlying cause of the alkalosis to restore the balance. Now the third one, it is due to carbon monoxide poisoning or methemoglobinemia or alkalosis that would be causing the left shift of the oxygen hemoglobin dissociation curve, and you are getting PaO2 to be high, but SpO2 is low. So you have to find out the hemoglobin abnormalities and also consider therapies like hyperbaric oxygen for optimal oxygen delivery. Now, something I have tried to explain the ODC in very detailed fashion. If at this point of time any question is there, you can like post in the chat box, or I will be going to the second question. Okay. Now, the second question is very practical, and we do regular basis. We analyze lactate, like no analysis the values in our critical care perspectives. So the question from the basic science, they will not be expecting that you would be writing only clinical, rather the physiology. So lactate physiology in critical care perspective, the overview will be related to the pathophysiology, clinical utility, and management. Now, before going to the detail about the lactate, in detail, lactate is actually a byproduct of glycolysis, and primarily it is produced under the anaerobic conditions. In aerobic conditions, the byproduct would be pyruvate. Now, this is cleared by the liver, almost 60%, and kidney, 30%, via gluconeogenesis or oxidation. Normal blood lactate is around 0.5 to 1 millimole per liter, but if it would be more than 2 millimole per liter, we normally label as hyperlactatemia. Now, there would be something you need to remember about the kinetics of lactate. The daily production normally is around 20 millimole per kg per day, and it enters the circulation, undergoes hepatic and renal metabolism, and the cycle, you remember, Cori cycle. In the examination, in the practical, some of the examiners would be very keen on guessing how depth is your knowledge related to the physiology part. So Cori cycle. Now the conditions, all tissues can produce lactate under anaerobic conditions. Now there is a relationship between lactate and pyruvate. What is that relation? The reaction that if you are smart in chemistry, so you can write also in your examination, pyruvate plus NADH, reversibly lactate plus NAD plus H plus, and it is catalyzed by LDH, lactate dehydrogenase. So pyruvate and lactate are in equilibrium state normally, and lactic acid with the pK of around 4 is fully dissociated into lactate and H plus at body pH, classifying it as a strong ion. So lactic acidosis is a strong ion that you should remember. Now, what are the tissues that can produce excess lactate? At rest, can you guess? Skin is the organ of our body that produces lactate to the maximum. But normally we feel maybe some or other like muscles or gut or the other like RBCs or heart that would be producing more lactate. No, it is the skin, 25% of the lactate production. Red cell 20%, brain 20%, muscle 25%, gut 10%. Now during heavy exercise, it would be shifting to the skeletal muscles. They would be the predominant source of increased lactate. During pregnancy, placenta contributes significantly and may transfer lactate to the fetus. So you have to avoid transfer of that lactate from the mother to the fetus, because that would be interfering with the fetal perfusion or fetal physiology. Now, in critical illness, like in the ARDS or sepsis, lungs become a major source of lactate production in sepsis and ARDS. Now, lactate metabolism and elimination already explained. Liver 60%, kidney 30%, and heart maybe around 10%. Metabolic pathway, I have already explained. Gluconeogenesis is 50% converted to the glucose, 50% oxidized to the carbon dioxide and water via the citric acid. And this would be, these pathways do not result in net acid accumulation but require aerobic conditions. Now, renal handling, almost 180 millimole per day of lactate is filtered by the kidneys, and nearly all filtered lactate is reabsorbed. So you don't feel that lactate is not produced in our normal physiology conditions, but our liver and kidney are so efficient, they actually metabolize the lactate to a great extent. That's why we do not get hyperlactatemia in our clinical state. Now, this is the Cori cycle. If somebody is interested to know, this happens in the liver, and this is the gluconeogenesis. This is the glucose, and you can see here the pyruvate, 6 ATPs, gluconeogenesis enzymes, lactate dehydrogenase is the catalyst here, the enzyme which is responsible for the change in the pyruvate and lactate cycle. And you can see this glycolysis dependent tissues, skeletal muscle, blood cells, bone marrow, renal medulla, peripheral nerves, and hypoxic tissues. There would be glycolysis dependent tissues. They need glucose. And if they don't get it, so they will be trying to go into the more of lactate production and less of the ATP production. Clear? And the lactate per hour, you can see 0.8 millimole per kilogram per hour. So this is something which you can draw. Liver is one side and other organs of our body, glycolysis dependent tissues like this, they would be in the other side. And you can see what happens through the gluconeogenesis and how LDH is helping to change from the pyruvate to lactate. Now, hyperlactatemia in critical illness. How does it actually having clinical perspectives in ICU? Hypoxia-induced anaerobic glycolysis is common in shock states. All types of shock. It is not only septic shock, cardiogenic shock, maybe neurogenic shock, anaphylactic shock. Now, impaired clearance will be normally associated with hepatic and renal dysfunction, because these are the two organs that metabolize lactate to a great extent in the normal physiology conditions. Now, increased aerobic glycolysis will be also leading to hyperlactatemia because of the stress-induced catecholamine surge. It is not only anaerobic, also sometimes the aerobic glycolysis will be also resulting in increase in the lactate level. Now, there would be some medications that would be also resulting in hyperlactatemia in our clinical perspectives, like beta agonists, metformin, propofol. Now, the pathophysiology, already we know why we'll be getting hyperlactatemia or lactic acidosis, because of mainly three mechanisms. Excessive tissue lactate production, that would be common in anaerobic conditions due to either inadequate oxygen delivery or utilization. There would be two positions or two states that would be resulting in excessive tissue lactate production. Now, the second one would be impaired hepatic metabolism in case of acute liver failure or chronic liver disease, where actually there is decreased clearance capacity, and that would be resulting in or leading to the lactate accumulation. Now, often a combination of many mechanisms would be contributing to the persistent lactic acidosis in critically ill patients. Now, again, what are the types of the lactate, hyperlactatemia or lactic acidosis? So you can see here the causes of lactic acidosis, Cohen and Woods classification that you need to remember. What is Cohen and Woods classification? That would be including two types, type A and type B lactic acidosis. Type A is mainly primarily due to inadequate oxygen delivery, and that occurs due to hypoxia or tissue perfusion deficit, and that would be due to anaerobic muscular activity, sprinting, or generalized tonic-clonic convulsions, tissue hypoperfusion like shock, that could be due to septic, cardiogenic, hypovolemic, post-cardiac arrest, during cardiac arrest, regional hypoperfusion like mesenteric ischemia, and the third one would be reduced oxygen delivery or utilization due to hypoxemia, anemia, carbon monoxide poisoning. So this is type A lactic acidosis, which is inadequate oxygen delivery. Now, there is another form of lactic acidosis, which is type B, where there is no evidence of inadequate tissue oxygen delivery, and that would be mainly due to resulting from the metabolic or toxic factors. And that would be again divided the type B into B1, B2, B3. And just remember, associated with underlying diseases would be B1, like leukemia, lymphoma, Luke. Tips. Remember, easy to remember: thiamine deficiency, infections, pancreatitis, short bowel syndrome. And third one would be all types of failures: hepatic failure, renal failure, diabetic failure. Diabetic failure, it would be diabetic ketoacidosis or HONC. So these are the three types of, like, no, the underlying diseases that would be resulting in type B lactic acidosis. Now, B2 would be associated with drugs and toxins. Remember the drugs that normally causes increase in the lactate level. In the exam, you should be writing beta agonist, metformin, salbutamol, isoniazid. Isoniazid is one of the anti-cox treatment that will be causing your lactate to be high. Toxins, in toxins, cyanide should be the first answer, methanol, ethanol in chronic use, and other substances like fructose, sorbitol, xylitol, and lactate-based dialysate in the RRT, in the dialysis. So these would be the drugs and toxins that would be causing type B lactic acidosis. Now, B3 would be the inborn errors of metabolism, like the enzyme defects, pyruvate carboxylase deficiency, glucose 6 phosphatase deficiency, or other oxidative phosphorylation defects. So this would be, in short, the Cohen and Woods classification for the lactic acidosis. Now, the more significant for our critical care, like, no, the practice would be lactic acidosis in sepsis. In examination, they would expect that explain the mechanisms by which there would be lactic acidosis in sepsis. So it would be a combination of mechanisms. One would be endogenous catecholamine release that would be contributing to increased aerobic glycolysis and lactate production. That would be point number one. Circulatory failure because of the hypoxia and hypotension, that would be now diverting the metabolism to the anaerobic pathway rather than the aerobic pathway. Cytopathic hypoxia because of microvasculature problem, the microvascular shunting, mitochondrial failure, that would be impairing the oxygen utilization at the end tissue level. Clear? Now, there would be also endotoxin effects because of the cytokines and endotoxins, like the surge that is happening in the septic saw, that would be inhibiting the PDH, pyruvate dehydrogenase. That would be again one of the, like, no, the pivotal, the enzyme that is responsible for your, like, no, the conversion from pyruvate glucose to pyruvate. Now, also in the sepsis or septic shock, there would be definitely coexistent liver dysfunction. So there would be also to substantial amount of reduced lactate clearance that would be again aggravating the lactic acidosis in these situations. So these would be the 5 causes of lactic acidosis in sepsis. Now, there would be something you need to remember how you are actually monitoring or measuring the lactate level. So through one, plasma lactate level, primary test, And if you are getting your elevated lactate is documented from the lab, so it would be crucial to now to identify and address the underlying cause. Now, for all of you, you should remember there is another form, isomer of D-lactate. What is D-lactate? This would be an isomer of lactate produced by intestinal bacteria, not by human cells. And the clinical relevance, you need to remember that this is not detected by the standard lactate assays that we do in our the bedside test. And this would be one of the potential bedside tests that are for diagnosing conditions like mesenteric ischemia. So mesenteric ischemia, it would be the intestinal bacteria that are actually right now releasing this form of lactate, that is D-lactate. So this would be more significant if you are getting D-lactate form, it would be signifying more towards the intestinal problem or mesenteric ischemia. Now, how would you be collecting the lactate sample? Venous versus arterial sample. Is there any difference between venous or arterial sample lactate level? No. Venous samples are clinically equivalent to the arterial samples in most of the cases. So you don't need to always order for the arterial blood like lactate level. So if you are getting the venous lactate also, you will be also pretty sure that yes, it is elevated means elevated. And you have to measure the trend of lactate levels through the venous or arterial. That is more important. Now, handling and tourniquet use. Do you really need to remove the tourniquet during sample collection for getting a good lactate level in your body or in your blood? No. But if you are actually trying to get the sample but you are not able to find a good vein and you are using the tourniquet for a long time, maybe you have to release the tourniquet for 20 seconds before collecting the sample. Now, the stability of the samples normally remain stable for 15 minutes at room temperature. And in on ice, if you are actually sending your blood sample for lactate determination or assay, and you are expecting delay in your analysis, so definitely on ice, you can send your the blood sample. Monitoring and follow-up is very important, and you have to repeat the lactate measurement rather than only depending upon a single value of lactate. Now, what is the clinical utility in critical care? It is a marker of hypoperfusion, indicates inadequate tissue oxygen delivery. Risk stratification, persistent high level of lactate in your ICU patient, that would be correlating with poor outcome. And also it would be a prognostic significance associated with mortality in sepsis, trauma, and cardiac arrest. So these are the three clinical scenarios where lactate is one of the the most important monitoring modality that would be giving you a clue that you are actually doing your resuscitation to a great extent successfully or not, and that would be also prognosticate your patients the clinical future or whatever outcome. Now the management strategy, resuscitation goal, it should be targeting lactate clearance more than 10% within 6 hours would be the first management strategy. Treat the underlying cause, whether it is sepsis, hypovolemia, cardiogenic shock, and adjunctive interventions like optimizing the oxygen delivery, put the patient on ventilator, give anti-epileptics if the patient is having the seizures, support the liver if it is liver failure, correct the metabolic acidosis, go for dialysis. Now the management of lactic acidosis, again the core steps I have already explained. You have to put the patient on ventilator, utilize fluids, inotropes, vasopressors, identify and treat the cause of lactic acidosis. Now the evidence for lactate level and lactate clearance, there have been multiple the trials that have been analyzed or conducted to prognosticate the value of lactate level. So if your lactate levels are high, so that would be directly proportional to the mortality risk, except salbutamol toxicity or seizures. Now, if you are getting lactate to be high, but your patient is having normal blood pressure and mental status, what will be the outcome? So lactate is an effective tool for identifying occult sepsis also. That means if your patient is perfectly fine, normal blood pressure, good GCS, but your lactate continues to be remaining high, just as in the reverse trial. 1 in 5 patients had MAP of more than 100 millimeter mercury, but with high lactate level. Now, lactate clearance, as I have already told, there have been a lot of studies that have been actually correlated with poor lactate clearance is linked to worse outcomes, especially in trauma. Then lactate clearance is non-inferior to your mixed venous oxygen saturation or your central venous oxygen therapy for guiding therapy, and EGDT beneficial in patients with hyperlactatemia. But only targeting to treat lactate concentration in your body is not at all recommended as per all the major trials. And there is another terminology that you need to remember is lactate gap. What do you mean by lactate gap? This is the difference between lactate that is measured by oxidase method, which is the normal standard method, and the dehydrogenase method. So lactate gap is actually the difference between oxidase lactate minus lab lactate dehydrogenase. So we are doing the FBG sample that is actually utilizing the oxidase method to monitor or measure the lactate. And in the lab, when we are sending the arterial sample, that is right now determining the lactate level by lactate dehydrogenase method. So the difference you have to actually monitor. And in the situations like ethylene glycol toxicity, glycolate is actually accumulating, and that would be leading to the false interpretation. That means you will not get the correct lactate level by doing the ABG. So you have to send it to the lab for determining the lactate level by the lactate dehydrogenase method, where you will be also getting to know about the presence of glycolate that accumulates in the ethylene glycol toxicity. Then there are certain treatment methods like use of sodium bicarbonate, but as per all the randomized control studies in lactic acidosis and shock, they didn't have any significant benefit on the cardiac function or overall pH correction. But you can always target sodium bicarbonate to decrease the lactate level, and the alternatives to sodium bicarbonate are carbicarb, dichloroacetate, or tris or tham. So these are the buffers. Carbicarb is the buffer without generating carbon dioxide. The side effect or disadvantage of using more of sodium bicarbonate is it would be generating carbon dioxide more. That we don't want. So carbicarb is actually one buffer without generating carbon dioxide. Dichloroacetate will be enhancing the pyruvate dehydrogenate activity, which is one of the problem area for going into the anaerobic pathway, and that would be actually going into release of more lactate level. Now tris or tham is non-carbonic acid buffer. Now, indication of bicarbonate therapy where you are actually trying to reduce the lactic acidosis for better cardiac contractility. So, severe ischemic heart disease, severe pulmonary hypertension. Now, at the end, if you are still not able to treat the high lactate level, you can subject your patient to dialysis or hemofiltration. Though hemofiltration can be a useful intervention, but the lactate production has to be stopped. The dialysis cannot stop the production of the lactate level. It will be removing the excess lactates, but in case of severe sepsis, septic shock, you are unable to actually control the ongoing sepsis or inflammation that is happening in the body. Now, the emerging insights at the end, the future directions, lactate as a therapeutic targets, use trends rather than a single value to guide your intervention. It would also put some light on mitochondrial dysfunction, like it would be contributing to sepsis related hyperlactatemia, and also sometimes lactate to pyruvate ratio will be helpful to differentiating between aerobic versus anaerobic production, whether your lactate is produced from the anaerobic pathway more or it is due to aerobic glycolysis pathway more. So you have to go for lactate to pyruvate ratio. Now there are certain challenges and limitations of our lactate physiology. It would be highly non-specific. Elevated level can be due to multiple causes. You need to go for a trained dynamic monitoring, and lactate fluctuations influenced by the sampling, timing, and the patient factors. And this is a one pager. I think everybody knows about. You can always go for all the the main headings to write in in 2 pages in your answer. What is type A, what is type B, then what is type D. This bacterial overgrowth that I have explained to you in short bowel syndrome or mesenteric ischemia, you due to type D of lactic acidosis. And the lactate clearance I have already explained. This is the Cori cycle. Then this is something related to the definition as well as what is lactate, what is lactic acidosis. So all these things you have to remember, so that in case you are getting a very usual and very easy question in your exam, you should not be getting less than 10 out of 10. That is my expectation at the end of this. Maybe I have taken 20 minutes to discuss about a topic which everybody every day is using, but they need to clearly understand the concept rather than just using it superficially. So, lactate is a cornerstone of critical care, reflecting tissue perfusion and metabolic stress, and its interpretation should be context specific, guided by underlying pathophysiology and clinical trends. I'm not going into again detail, but I have kept questions at the end of each like no the scenario that this is a clinical scenario. In case the lactate physiology will not be a direct question, the examiner may ask in a different format. Like a 65-year-old patient with septic shock has a serum lactate of 5 millimole per liter. Despite fluid resuscitation, lactate remains elevated. Now, the question would be, what are the key mechanisms leading to elevated lactate in septic shock, which I have explained nicely. 5 mechanisms I have shown you in my slide. And how does this guide your management strategy? That also I have explained. Now, a conceptual question would be, in a critically ill patient, a lactate level of 3 millimole per liter is detected. Now, the patient is hemodynamically stable but has a low PaO2. Now explain how lactate production can occur in both aerobic and anaerobic conditions and why elevated lactate might not always indicate hypoxia. I hope all of you understand this question, which is little bit twisted to know the in-depth understanding of yourself to like this lactate physiology. So I'm just sharing with you this. I have already explained to you the elevated lactate level in septic shock. The second one I'm trying to show you that the lactate production in different states like anaerobic condition and aerobic conditions. Aerobic condition I have already shown you hypermetabolic states, exercise, fever, beta adrenergic stimulation, mitochondrial dysfunction. But the key insight for the second part of the question would be that elevated lactate doesn't always imply hypoxia. Rather, it can reflect systemic stress or metabolic adaptation. And elevated lactate in the context of clinical findings like perfusion status or oxygen delivery or acid balance is more important. Now, this is all about lactate. Now, the last part of my assignment is tracheal anatomy and tracheostomy. This is again a very favorite question because we go for like no airway management on and off every day. We do bronchoscopy, we do tracheostomy. So this is imperative that any clinician who is working in ICU should be knowing in detail about trachea as well as tracheostomy. Now, trachea, commonly known as windpipe, which is a crucial component of the respiratory system, and this is one like main conduit for air passage between larynx and lungs. To L, you are getting T. Now, understanding its anatomy is essential for effective airway management in critical care settings. Now, it is a if the question would be coming as tracheal anatomy, so definitely you have to write minimum 1 page about the anatomy. So it is a fibrocartilaginous tube about 10 to 11 centimeter long, and it begins just under the L and runs down behind the sternum to meet again L, that is lungs. So larynx and lungs in between trachea. Now the trachea divides into two small tubes called as bronchus, and one bronchus for each lung, right bronchus, left bronchus. Now, the main function of the trachea is to transport air in and out of the lungs during the act of breathing. It protects the respiratory tract by warming and moistening the air and propels foreign particles upward towards the pharynx for expulsion by coughing out. Clear? Now, mucus in the trachea also helps capturing the microorganisms such as viruses and harmful bacteria before they enter the lungs. This is the first few lines about the trachea. Now, this is a picture. You need to draw at least 2 to 3 pictures related to trachea if you are getting the anatomy question. And the physiology question would be the airway passage, or tracheostomy would be the procedure. So, I am not going into detail. This is the hyoid bone. Then this would be thyroid membrane. This is the superior thyroid notch, anterior thyroid lamina. there is cricoid cartilage, cricothyroid membrane. The cricothyrotomy again is a question, potential question. This is the thyroid cartilage as a whole. The thyroid cartilage, cricothyroid membrane, thyroid membrane, and hyoid bone. It easy to draw. And then you have to draw the trachea here, and then it divides into right main bronchus and left bronchus at the carina level. Clear? So this diagram has to be there on your first page. And then what are the relationship of trachea and bronchi to the other organs, other structures surrounding the trachea? So tracheal anatomy, because that is again important for your tracheostomy, intubation, bronchoscopy. Now cricoid is at the level of C6, and the trachea again divided into cervical trachea, thoracic trachea. Cervical trachea is 5 centimeter, thoracic trachea is 5 centimeter. Just remember 10 centimeter divided into cervical trachea 5 centimeter, thoracic trachea 5 centimeter. Now this is the thyroid isthmus, suprasternal notch, manubrium, and the bifurcation occurs at the level of T4-5. Again, you have to remember these labels in the examination. They would be very keen on asking you T4 or 5. Now the right bronchus, there are certain specification about right bronchus: wider, shorter, steeper, around 2 centimeter. Now the left bronchus would be narrower, longer, more horizontal, and 5 centimeter. Now this trachea is around 10 centimeter, but the peculiarity of the trachea is it can elongate to 15 centimeter during inspiration. So if you take a deep inspiration, your trachea can elongate to 15 centimeter around. And the histologic layers, mucosa is ciliated, pseudostratified, columnar, hyaline, and cartilage rings are there. I will be explaining that. Now, the specification about the trachea ending in the bronchus is inhaled foreign body are more likely to enter the right bronchus and then pass into the apical bronchus of the right lower lobe, the first one that points posteriorly. So that's why the pulmonary cox, you will get the apical portion will be the first, right side apical, the bronchus would be the first part to be you will get the hedginess there. Now relationship of the trachea here: anteriorly sternum, sternothyroid muscle, arc of aorta, brachiocephalic trunk, left common carotid artery. Just remember trachea is here, and you are getting all the vascular structures: arc of aorta, brachiocephalic trunk, common carotid artery, and right main bronchus, left main bronchus. Clear? Now, posteriorly, esophagus, vertebral column, easy to remember. Right side, right lung, right pleura, right vagus nerve, and azygous vein. Left side, arc of aorta, left common carotid, left subclavian. So there would be vessels on the left side, there would be vessels as well as the right lung and pleura on the right side. And posteriorly, there would be esophagus and vertebral column. And that's why the relationship you need to remember, because you have to be cautious during intubation. If you will be doing wrong intubation, it will go for the esophageal intubation. During the central line, if you are actually going into a wrong direction, you will be hitting the right lung and pleura, resulting in the pneumothorax and tracheostomy. Everybody knows the complications or the challenges that we normally encounter if you are actually getting the anatomy not very clear or to our the clinical examination. Now the structure of trachea, you have to also remember that there is a D-shaped fibrocartilaginous respiratory organ. So it would be D. The backside would be a straight line. Consist of 16 to 20 tracheal cartilages anterolaterally, and a fibromuscular wall posteriorly. And that muscle name is, can anybody mention in the chat box what will be the muscle that is fibromuscular in nature and that remains at the posterior side of the trachea? Yeah, I think people are getting, I'm not checking. That is trachealis muscle. Okay. Now, tracheal cartilages are composed of hyaline cartilage and interconnected by fibroelastic tissue. So it would be all cartilages would be hyaline, and that would be interconnected by fibroelastic. And what is the significance of that? They support the trachea and keep it open during pressure changes that accompany air ventilation. Otherwise, it would be also collapsing during your expiration. That we don't want in the normal anatomy or physiology. Now, the posterior wall of the trachea, as I have already mentioned, is formed by trachealis muscle, making cartilages appear as incomplete C-shaped. C. or whatever we are mentioning as D, because D would be the stem, would be the fibrocartilaginous, the trachealis muscle. And the structure of its wall makes the trachea sufficiently flexible and elastic to permit transient expansion of the esophagus also during swallowing. That is the beauty of trachea, the anatomy. Backside, if it would be again a very tough structure, then esophagus won't get that, like, no, the peristalsis movement during the swallowing. So that's why the backside would be trachealis muscle, and that would be very flexible. So you can actually swallow water or food without any impingement on the tracheal wall. And this is the structure diagram. Again, you have to remember, in this class it would be difficult to mention, but again you have to remember the most important, all the cartilages and the trachea. And the trachea, how does it look like? The lumen of the trachea is this. Backside is the esophagus. This is the trachealis muscle, which I was mentioning. And this is very soft and expansile. And the mucosa, the hyaline cartilage, the structure is made of hyaline cartilage. And there would be glands also that would be secreting mucus, submucosa, mucosa. Histologic layers I have already mentioned: mucosa, mucous membrane, and that would be pseudostratified ciliated columnar epithelium, goblet cells that would be producing mucus, which warms, moistens, and removes the foreign particles from the air as it flows through the trachea. That would be a defense, first defense mechanism. Now the submucosal layer is the second histologic layer of the trachea. That would be consisting of loose areolar connective tissue that contains also mucous glands, smooth muscle, vessel, and nerves. The submucosa contains the vessels and nerves. Musculocartilaginous layer, which is the third layer of the trachea, again that would be the C-shaped cartilaginous ring, and there is just intervening smooth muscle. And this would be narrowing the tracheal lumen and increases the velocity of the airflow. If there would be any dislodgement of the mucus and foreign particles would be entering, it would be actually trying to remove it, and that would be like taking it out with the velocity of the airflow. And the last one would be adventitial layer. This is a band of connective tissue, and that loosely bind the trachea to the esophagus and other nearby organs. So mucosa is the inside, then submucosa, then the muscle or muscle cartilaginous, and finally adventitia. This is the nerve supply and arterial supply. You have to remember, look, this looks little bit that I am going into the anatomy or physiology class, but in your examination, you will remember me if you will get the tracheal anatomy and tracheostomy for sure. The first thing you will remember is me. Okay. Nerve supply of the trachea, sensory nerve supply from vagus and recurrent laryngeal nerve. Just remember, you don't need to again go into detail, like, till what extent there would be vagus, then what extent would be recurrent laryngeal nerve. No. Blood supply, again there is a peculiarity of blood supply of the trachea. Upper 2/3 is inferior thyroid and lower 1/3 is by bronchial artery. Clear? And about the lymph drainage of the trachea, pretracheal and paratracheal and deep cervical nodes. Clear? So these are the three things that you need to remember if you are getting a tracheal anatomy question. The functions, I hope everybody can write about 4 to 5 lines, but you have to remember to mention about the goblet cells, the mucus, then the physical and immunologic methods, then the transport of the oxygenated air from the upper respiratory tract towards the alveoli, then again the temperature regulation by, like, making the air, dry air moistened. So all these things you need to remember. And also finally the cough reflex, that would be also one of the protective mechanism. And on cold days, again the trachea helps warming also and providing humidity of the to the air before it reaches the lungs. Now the clinical significance of the tracheal anatomy. First is airway anatomy. You need to be very clear about tracheal anatomy for procedures such as endotracheal intubation, tracheostomy, bronchoscopy, proper tube placement, avoiding injury to the adjacent structures. Pathology conditions, like tracheal stenosis, tracheomalacia, tracheoesophageal fistula, that would be definitely requiring proper anatomy understanding for effective diagnosis and management. And finally, emergency situations, life-saving situations in case of acute airway obstruction. If you know the tracheal anatomy properly, so you can go for cricothyrotomy, which is like, putting the needle through the cricothyroid membrane located just below the thyroid cartilage I have shown. So that also is very important. If you know the tracheal anatomy properly, you can do the cricothyrotomy procedure effectively. Now, the last part of my assignment is the procedure itself, tracheostomy. That can be a question from the intervention or procedure like no domain. Now, tracheostomy, as the name suggests, tracheostomy is a surgical procedure that creates an opening in the anterior wall of the trachea to facilitate airway access and ventilation. Clear? Tracheostomy, anterior wall opening, facilitating airway access and ventilation. Now, there is always interchangeable terminology like tracheotomy. What is tracheotomy and what is the difference between tracheotomy and tracheostomy? Tracheotomy is a procedure, just simple remember, directly connect the trachea with the skin of the neck. Always tomy or stomy is to like connect with the outside skin. So if the trachea is directly connected with the skin of the neck, it is tracheotomy. Like laryngectomy, following laryngectomy, what is happening? The larynx is actually completely taken out. Now the transected trachea is directly anastomosed with the skin of the neck. So that is tracheotomy. Now, in that tracheotomy track, a tracheostomy tube also can be placed. So it is not, tracheostomy is the procedure. Tracheotomy when you are actually directly connecting the trachea to the skin. Now, what are the indications of tracheostomy? The first thing that you have to write in your question, if it would be coming, three indications normally. One is to bypass the obstruction of the upper airway. So you are actually not going through this route. You are actually directly entering through the trachea. Second one, to provide an avenue for removal of secretions retained in the airways for your the neuromuscular weaknesses, or when you are thinking that the airway protection is not good. So that would be also one of the indication. And the third and the most important from the critical care perspective is to provide means for prolonged ventilatory support, where you are actually expecting that by doing tracheostomy, you will be going to do better for the patient's recovery. Now, the indication can again be divided into multiple ways. I am trying to summarize in three methods. One is emergency indication, one is elective indication. This is the first method by which I am trying to explain. Now, emergency indication, where you are getting acute upper airway obstruction due to multiple causes like angioedema, anaphylaxis, when endotracheal intubation is actually failed and you don't have any other thing to do. Infections like submandibular space infections, Ludwig angina, retropharyngeal abscess, or any obstructive mass like tumors or foreign body is actually lost in the upper airway and you are unable to enter through the upper airway. So you have to go for emergency tracheostomy. Now the second one would be post-emergency cricothyrotomy. You have already done cricothyrotomy. Now you have to change it to tracheostomy. Definitely, you cannot continue with cricothyrotomy for a long time. Now, severe facial or neck trauma, where you are unable to put any endotracheal tube, like Le Fort 3 fractures or more. Now, fourth one would be penetrating laryngeal trauma, where there is a trauma directly to the larynx. So you cannot go into the larynx part. You will be going into the trachea part, straightforward. Now, the elective indications, what we normally do. So prolonged mechanical ventilation, impaired airway protection, refractory OSA is again one of the indication for going for elective tracheostomy. Severe subglottic stenosis, severe vocal cord paralysis, where all other treatments have failed. This is the first method of classifying the indication. Now the second method is where the traditional method, upper airway obstruction, impaired clearance of secretions, and third one is prolonged ventilatory support. Now, just remember the structure, the format. You can write n number of things. I'm not going into detail. Upper airway obstruction, just remember what can be the upper airway obstruction pictures. Then impaired clearance of secretions. Again, I have already mentioned when you are unable to clear the secretion, neuromuscular diseases, and prolonged ventilatory support, which is our day in and day out tracheostomy indication, extended mechanical ventilation, when you are expecting long-term ventilatory support. Now coming to the contraindications, the contraindication again absolute and relative. Now the absolute contraindication, when there is no cervical trachea itself, how will you go for tracheostomy? Then uncorrectable bleeding diathesis, when you are getting like very high INR with platelet count low, and you are expecting that would be torrential bleeding during the procedure. Now, relative contraindication will be the hemodynamic instable. Patient is requiring very high FiO2 and PEEP more than 12 or so. Severe hypoxemia. So you cannot do the procedure within maybe 1 minute, 2 minutes. And there would be many relative contraindications for percutaneous tracheostomy. That also you need to remember, because the next part would be the types of tracheostomy. In that, we'll be discussing about the open tracheostomy and percutaneous tracheostomy. Now, relative contraindication for percutaneous tracheostomy is morbid obesity, short neck with inability to identify and palpate the trachea. This is relative. I'm not saying absolute. Vascular structures such as high riding innominate or thyroid internal mammary artery, and you are doing ultrasound and you are getting a big vessel just in front of the trachea. Gross distortion of the neck from hematoma, tumor, thyroid, big thyroid, scare is there. You are not getting the anatomy properly. Severe tracheomalacia, and all the cartilages have been destroyed. So you will not be able to get the proper the insertion site. Inability to safely extend the neck, like cervical fusion, rheumatoid arthritis, or other causes of cervical spine instability. Prior complex tracheal surgery have been done, and the surgeon is not very keen to go for tracheostomy in this patient, where you will be going for percutaneous without knowing the proper anatomy of the the tracheal surgical patient, like tracheoplasty, tracheal resection, reconstruction. Previous tracheostomy is not a contraindication though. Children less than 15 years. Can anybody tell me what is the reason why children are not supposed to go for percutaneous tracheostomy? Because it is so flexible. The trachea has not been grown to the proper extent. So you will be trying to actually hinder the growth of the tracheal cartilages. So that's why if it is indicated, again, that has to be done in proper open surgical method. And patients requiring emergency airway. Emergency airways, doing a percutaneous tracheostomy, sometimes you will be losing the airway completely. Clear? Now, what are the advantages of tracheostomy? What are the disadvantages of tracheostomy? That can be again another part or the stem of the answer. So avoid would be avoid direct injury to the larynx, because you are bypassing the larynx. Facilitates nursing care. You know everything, but you have to make it in a very structured way in your answer sheet. Enhances patient mobility, more secure airway, improved patient comfort, permits speech. In intubation, you cannot talk. The patient cannot talk. Provides psychological benefit, more rapid weaning from the mechanical ventilation, better oral hygiene, decreased risk of nosocomial pneumonia, more significantly BAP, ventilator associated pneumonia, or hospital acquired pneumonia. Disadvantages, definitely complication would be one of the risk factor. Bacterial airway colonization, cost would be a factor. Surgical scare maybe sometime will be there, and tracheal and stomal stenosis and other complications of the tracheal stomy. Now, what is the timing of tracheostomy? There is actually a bit of controversy about the timing of tracheostomy. So the examiner may wish to check or assess whether you are clear about the timing of tracheostomy. General recommendation: early tracheostomy within 7 days of intubation, late tracheostomy after 7 days. Now there have been multiple studies that have been conducted. One meta-analysis in 2005, then 2011 meta-analysis, then the UK study, that is the TrackMan trial, published in the JAMA. So all these studies, they have tried to find out what should be the ideal timing for the tracheostomy. And all these studies, the clear verdict is not there. So the first meta-analysis that suggested that if you're going for earliest tracheostomy, the complication will be less. Now, contradictory evidence was in the 2011 meta-analysis, where they have included 7 RCTs. Almost 1,000 plus patients were there, but they didn't find any significant difference in mortality rate or mechanical ventilator days or ICU length of stay. Now, the third one, which is one of the favorite question from the examiners. If you are getting a tracheostomy case in your practical, the examiner would be expecting to just utter the word TrackMan trial. Okay, I will be showing you the screenshot of the TrackMan trial also. This is UK study, 909 patients. They compared early tracheostomy, but the early tracheostomy here is 4 days, not 7 days. Try to remember this. First 4 days, if you are doing tracheostomy, it is early. Late tracheostomy would be after 10 days, or if indicated. And they didn't find any difference in the 30-day, 1 year, 2 year mortality. Similar ICU stay, and antibiotic use between the groups. But significant thing is median sedation days were lower in the early group, P less than 0.001, 5 days versus 8 days. That is quite significant. And tracheostomy was avoided in 53.7% of the late group. That is again one of the criticism for this study, that if you are going for so early tracheostomy, almost if you are waiting for the late tracheostomy, you are avoiding in almost more than 50% of the group. So that is definitely something which would be antagonizing the idea of going for early tracheostomy. So the conclusion from the recent evidence that benefits of early tracheostomy are not strong enough to recommend performing the procedure before 7 to 10 days of intubation. Now, delaying tracheostomy often avoids unnecessary this type of procedure and their associated complication. And this is the TrackMan trial. So I have just shown you this picture published in JAMA in 2013, and this is related almost 1000 plus patients were recruited. Now these are some of the current evidence of all the trials, RCTs and meta-analysis about the tracheostomy timing. This is the mixed ICU RCT, all the RCTs. Again, just remember the 2-3 names that would be something which would be helpful to you. Now, what are the types of procedure of tracheostomy? Surgical tracheostomy, the first and foremost, where you will be shifting the patient to OR under sterile condition. You will be doing now percutaneous tracheostomy, bedside in ICU using minimal invasive techniques. The major difference: surgical will be preferred for complex anatomy or emergency airway. Percutaneous, it would be faster, less invasive, and fewer complications in stable patients. Now, what are the techniques of percutaneous tracheostomy? That again be one of the part of your question. So it can be Siaglia method. Key feature is sequential dilatation. Standard ICU patients, we do blue rhino, single step, curved dilator, faster, less tissue trauma. Griggs method, forceps based blunt dilatation, quick but requires more skill. PRDT is rotational dilatational motion. Now this is complex and or delicate trachea. You have to do it rotating and dilating rather than single step curve dilator. Balloon dilatation, where you are using balloon catheter for dilatation. Fragile tracheal structures. Pantoni method, which is by translaryngeal approach. Contraindicated anterior neck puncture, where you are not supposed to go for the anterior neck punctures. And finally, ultrasound guided. Ultrasound precision, high risk patients like obese or abnormal anatomy where the vasculatures you are not sure to go blindly. So definitely, and you can combine ultrasound with your bronchoscopy for every procedure. Before going for the procedure, you can do the ultrasound, assess the vascular structures around the anatomy of the neck, and then go for the procedure. Now the complications, again, that will be again divided into immediate, early, late, long term. In immediate, bleeding, pneumothorax, tube displacement. Early, infection, subcutaneous emphysema. You have done the procedure. Next day when you are coming for the round, there is no subcutaneous emphysema. Tracheitis, infections, inflammation. Late would be tracheomalacia, fistula, stenosis. Long term, definitely there would be some person of patients where you will be getting voice change, or there would be some cosmetic concerns that will be also there. Now, again, another way of answering: immediate complications, intermediate complications, late complications. Immediate complications, common, all the things that you can think about when you are doing the procedure, what can happen. Immediate complication, when it would be day 2 onwards, day 1 to day 7. Persistent bleeding, tube obstruction, displacement, atelectasis, something like that. Late complication, when you are getting it more than day 7, like fistulas, malacia, or stenosis, necrosis, fistula, again, or tracheoesophageal fistula also sometimes happen. And functional and quality of life issues like major aspiration, speech deficit, swallowing deficit, tracheocutaneous fistula, that would be something which is coming more than 7 days. This is again one pager related to this percutaneous dilatational tracheostomy. So this is something just to you can how you are actually mentioning in your answer sheet, but you don't need to write the procedure itself. No examiner expects you to put the pictures of the procedure. Rather, it would be indication, contraindication, complications, types, then the specialties, how you will be doing the post procedure care. So that would be something every examiner expects you to know. Now the last one, as usual, it would be clinical case rather than giving you a direct question about, write down about 2 pages about tracheostomy, I would be expecting my examinee to get this type of question. A 55-year-old mechanically ventilated patient with ARDS has been intubated for 10 days. Now, the intensivist recommends a tracheostomy, but the patient's family expresses concern about potential long-term complication. Now, the question is, how would you explain the benefits of tracheostomy compared to the prolonged endotracheal intubation in terms of patient comfort, ventilator winning, and complications while addressing the family's concerns? This is a format of question that you may get if the examiner, the question setter would be asked like maybe this is something like, no, they would be keen to know your clinical acumen, so they would be framing this type of question. So you have to mention about the improved comfort, facilitates winning, reduced complications. This would be the benefits. Long-term concerns also, you have to explain to the family about the complication risk, the reversibility nature of the tracheostomy, that it is a very temporary method and it can be removed once the patient recovers, and also showing the communication skills for a difficult patient like this, where nothing is like no very much as per your own like no the estimation. So you can show empathy and share decision making by reassuring the family that the decision is tailored to the best of the patient's interest, balancing the current need, the risk benefit ratio with long term outcome, and involve a multidisciplinary team like respiratory therapist and ENT to provide comprehensive care and support. Thank you very much. And just at the end, maybe instead of like no tracheostomy, you may get a question like cricothyrotomy, simple cricothyrotomy. So just one page about cricothyrotomy. The advantages we all know: technically simpler, faster, low complication rate, bedside procedure, doesn't require hyperextension of the neck, minimal encroachment on the mediastinum, the vasculatures, the esophageal injury will be less. Application would be in the trauma management, cervical spine injury, where you don't have like no the expertise, as well as the patient is not giving you that like no field where you can go for extension of the neck to do the tracheostomy. Emergency settings, when you are unable to go for oral or nasotracheal intubation and you do not have the like no the expertise to go for like no tracheostomy. Contraindications, definitely airway obstruction below the larynx, you cannot go for the cricothyrotomy in those patients. Primarily the patient is having laryngeal trauma and or tumors and infection, you cannot do. And children less than 10 to 12 years, because there is a high chance of going for like no subglottic stenosis or transection, and better rather than you should go for percutaneous needle catheter ventilation, the jet ventilation, something like that. And the cricothyroid membrane, everybody should be aware. You should go tomorrow if you are still not clear where is cricothyroid membrane. This is life-saving emergency procedure located 2 to 3 centimeter below the laryngeal prominence, that is the thyroid cartilage. It is easier to access due to superficial position. Complications are like no, there would be complication, but it is very less. And the procedure has to be like no transition from the cricothyrotomy to the standard tracheostomy within 2 to 3 days to reduce the complications. Thank you very much.